Thanks, Rick. Thanks for the invitation to speak. So I'm going to talk about MRD and CLL really in the era of novel targeted therapies as we move forward. And this just leads, just my disclosures for completeness. Okay, first of all, I think we have to think about MRD and what MRD is. We tend to think of MRD as minimal residual disease, but it's probably better to think of it as measurable residual disease because it's very dependent on the assay we apply and how sensitive that assay is, and this is across all diseases. So, for example, if you have a patient who has a single cell in 50,000 leukocytes, by our current criteria of 1 in 10 to the minus 4, 1 in 10,000, this patient will be MRD negative, but even our flow cytometry-based assays are more sensitive than that now, and this patient, if you had a cutoff of 1 in 10 to the 5 or 100,000, would be MRD positive. So I think it's worth considering our tests and the sensitivity of our tests. And the accurate assessment of disease is probably a way that we're going to use this sort of assay. So we can use MRD as a positive or negative as a prognostic marker, or we can use it to actually understand the behavior of a patient, an individual patient or a group of patients to therapy. And I'll try and show you what I mean by that by the absolute number. So I'll cover these 5 issues, the first 4 fairly quickly, which is really validating MRD and how we use it, where we look at it in CLL. And then I'll spend half my talk really talking about where we're going and how we're going to apply, or how we are applying MRD analysis to the targeted therapy era. So first of all, are we measuring MRD or are we measuring a surrogate? And I've put up on this slide the example of CML. So I think most of us who treat CML are familiar with using MRD to define duration of therapy or the type of treatment amongst multiple treatments. But we have to remember that this is a surrogate of MRD. So this is a PCR for RNA, and it's a ratio. So it doesn't measure tumor cells, it measures the expression of a gene in a tumor cell. And as you can see in the cartoon, we've used it in this particular patient to modify treatment and successfully brought the patient back under control. But a change in the BCR-ABL transcripts could be either due to the cells are there but they're not expressing the oncogene, or the cells aren't there. And we probably see that when we stop therapy, that we see that some patients relapse very quickly, and presumably those are patients who have disease or some maybe stem cells of CML disease that are sitting there waiting to escape from control. Whereas with CLL, whichever test we use, and we will be applying, I think, both flow cytometry and the next generation molecular testing, high-throughput sequencing, and I'll show you the data we have, we're actually measuring the individual cells, either the DNA, so a single immunoglobulin gene per cell, or the cell as shown in this cartoon. So a change in the CLL count means that there's a change in the level of disease in that sample, not necessarily in the patient. So, and it's really important to think about the specimens we're looking at. So we've spent a lot of time, for Andy Roster and many collaborators around the world have spent a lot of time standardizing and validating flow cytometry and molecular tests of MRD. And this started for us in the mid-1990s with the advent of Campath. We're developing an assay which was reliable, standardizing it through multiple groups around the world, and then eventually applying to the regulatory authorities. And in 2015, this assay an MRD was accepted by the European Medicines Agency as a surrogate for conditional approval of drugs. We're not quite there with the FDA. They want more information across for a variety of reasons, but we're certainly getting there where we have appropriate assays. And the next generation of these, which were actually we're now moving to 8-color, but 6-color flow cytometry validated. We published a paper Andrew did in 2016 with multiple different antigens, and we showed across many labs, and the authors are shown there around the world that this is an appropriate and validated and sensitive assay down to below 1 in 10 to the minus 4. We also showed that this is compatible with therapy, so it's very important as a surrogate that it's not just effective or measurable with a single type of treatment. So as you can see here, these assays will work with venetoclax, chemotherapy, ibrutinib-based treatment. So it's very important that the therapies we use do not interfere with the assays that we're performing. And then what we have to do next is validate that in clinical trials to show that these assays are important. So this is showing those assays applied to FCR-based treatment from the UK trials with over 400 patients treated, 29 that were analysed. And you can see the top curve are the MRD negative PRs, the red is MRD negative CRs, and then you've got the greens MRD positive CRs, and then the worst are the MRD positive PRs. So very few patients are actually MRD negative PRs, and it's because they have small residual lymph nodes or very slightly enlarged spleens. And actually, the EMA have accepted that MRD negativity is important whether you're in a PR or a CR. So we've validated this type of assay going forward. What about high-throughput sequencing? Obviously, there's been a desire to get more sensitive tests. This shows a dilutional experiment, which again we published recently, where we diluted CLL cells into normal, and you can see with 3 cases, the black spots are the average for 2 runs, that this test is valid down to around 1 in a million cells. Although as you get down to 1 in a million, there's a slightly wider distribution away from the black line, which would be absolute accuracy. So it's harder to quantitate it at very low levels, but probably more sensitive than flow cytometry if we need that level of sensitivity. And again, this has been validated by another group. So this is MRD now at 10 to the minus 6. So 1 in a million cells. And you can see in the blue curve, patients are doing better. So whatever assay we use and whatever level we pick, MRD negative patients do better than MRD positive patients. But what you can see on the right, this is a comparison of allele-specific PCR and high-throughput sequencing, that there's a group of samples that are negative by ASPCR but are positive by high-throughput sequencing. So we can say that this is a more sensitive test, and almost certainly will be a test we take forward in the future. Oops, sorry, let's go back. So our tests, both flow cytometry, certainly flow cytometry is validated and compatible with our current therapies. We still have to do more work on high-throughput sequencing to make sure that is appropriate, but it looks like it will be effective, and we're prospectively testing it now. So what about tissue? So what samples should we look at? One of the challenges has been using marrow, and it's likely in the future we won't have to do that with all therapies. So if you look at, this is data again that we've generated. On the left is FCR-based treatment. So this is where we've looked at both blood and marrow at the same time point. So in the green curve are double positives, blood and marrow, and you can see they do worse. But the 2 other curves are either a bone marrow positive, blood negative, or blood negative in both. And at a 3-year follow-up, there's no difference. So peripheral blood in this context with FCR can be used as a prognostic marker. Whereas if you look at another therapy, Campath, it's clear that the peripheral blood negative bone marrow positives have a lot of disease, and actually those patients in the blue curve are like the double positives. So the type of therapy you're using will affect different compartments. I'm going to come back to the FCR and the 3-year follow-up in a moment. So we've looked at a number of different therapies and had paired blood and marrow samples, and you can see this shows rituximab, so mainly FCR-based treatment, and you can see there's a difference in which there's a group of samples which are negative in the blood and positive in the marrow, up to 1%. And so the median difference between blood and marrow is just under 1 log difference. So rituximab clears the blood slightly more effectively than the marrow. So if you're positive in the blood, you will be positive in the marrow, but the converse may not be true. If you look at the FCR data and the patients who are blood negative, marrow positive, on the left is 3 years, on the right is a further year's follow-up, you start seeing the separation of the curve. So if you're going to move towards, if you like, cure and get rid of disease completely, as you go out further with this, where there's a difference between blood and marrow, we see a separation in the survival curve. So marrow is a more effective tissue to look at when using rituximab-based regimes. What about the novel therapies? Well, with single agent, this is from 2 of our trials in the UK, the ICL and Caliber trials, and you can see there's really, as far as we can tell, there's no difference, but we don't have very low levels of disease as yet with paired samples. We haven't been doing marrows very late out systematically, although we're collecting that data now. If we add obinutuzumab, this is one of our trials where we add obinutuzumab to ibrutinib, we see a difference. So again, obinutuzumab has a preferential clearance of the blood compared to the marrow, and it's about half a log difference. But there are some patients who are negative in the blood and positive in the marrow. So we have to think about the therapies we're using when looking at the tissues. What about in the era of novel therapy? Is MRD eradication still important? Well, it clearly is. So we have data from the venetoclax. This was presented by Andrew Roberts at last year's ASH, across all of the patients treated in a number of trials, that those patients who are MRD negative with venetoclax have a better progression-free survival than those who are MRD positive. So it's reasonable to consider that MRD negativity, if we achieve it with novel therapies, will be significant. So then I'm just going to now concentrate on what we're doing and what we should be doing with this type of approach with the novel agents. So first of all, we can use MRD, as I've shown you with chemotherapy, as a surrogate in groups of patients to look at overall survival. And it's certainly in Europe for conditional approval of drugs, which is really actually very important. And so this shows the same data, but now split in a different way. So the black line are the MRD negative patients. The blue line is a marrow between 1 in 100 and 1 in 10,000 cells. And the red are patients who have over 1% of cells at the end of treatment. And obviously, so the level of disease, not just positive or negative, influences outcome. In fact, you can do this in more detail, so we'll now split it by log reductions, and for every log less disease, you get about a year or slightly more better PFS. So you can see the light blue line is for over 10% in the marrow and so on. And actually, you can use this information to model what would happen if you had 10 to the minus 5, 10 to the minus 6, 10 to the minus 7, and predict the level of disease you need to achieve to actually get a very durable, potentially curative approach. So that's one way of trying to assess how low we need to go, although we can't measure it below probably 10 to the minus 6, and we probably will struggle to in the future. What you can see here is that the majority of patients actually are MRD negative in the black line, and then there's relatively few patients who have over 10% of disease. And one of our statisticians, Walter Gregory, who's spent his life looking at MRD in a variety of diseases, has modeled this. And actually what we see with our CLL trials is that there are a small proportion who are MRD high levels, and then it's the bottom end, it's the top end of a normal distribution. So most patients are low MRD positive. And so what you can then do is build in the other just over 50% of patients and predict that some patients will be just below the line and will be destined to relapse, and a proportion of patients are low enough to potentially be cured. And we see this from FCR series around the world. So the MD Anderson, about 30% of their patients are in long-term sustained remissions, and we predict about 15% of our patients across the UK in our trials will also achieve that. So we can use, if you remember this normal distribution, because if we push this down, we're going to increase the cure rate, and this is part of our modeling. Oops, sorry. So can we apply it to relapse? So that's response and prediction of outcome, but this slide shows 32 patients that we have followed over many years now in Leeds, after chemotherapy, antibody treatments, various other therapies, not allotransplant. And you can see that once a patient becomes MRD positive at a low level, their disease continually increases until the patient progresses. So you can use MRD level to predict progression-free survival. And you can see in this curve, there are patients who are MRD positive at a low level, but take many years before they actually become clinically apparent. And these two patients, for example, have the same doubling time, but obviously relapse at a different time point because of the level of disease they achieve. So you can use this again to model progression-free survival. So this shows a doubling time of 6 months for a patient, or that you'd have, it takes 1.7 years for it to go up a log and so on. So you can model the relapse of a group of patients by the depth of remission and the doubling time of the tumor. So if we go back to an individual patient, if you think about treating a patient into remission, with an MRD negative remission, we've still got probably 10 to the 7 or 10 to the 8 cells or up to that level. But if we can push the disease down to below a certain level, say 1,000 cells in the body, we can't measure it, then with a doubling time of 6 months, it takes 6 years for the disease to become apparent at an MRD level and 14 years for the patient to progress. So we can define the level of disease we're trying to achieve. And I was going to show you a couple of patients who are treated with the novel agent. So this is, they're novel agents. This is a young patient. She's a year older than me, so she's definitely young. Failed fludarabine, failed bendamustine, had a transplant, which she relapsed after. Didn't respond to DLIs, and then she was referred to us for trials in March 13. This is what she was like when we saw her, relatively big nodes, falling counts, 17p deleted and 11q deleted, and she started ibrutinib. And so this is her response. So she responded very quickly in terms of her nodes. This is before, this is at 8 weeks of a scan. Spleen's gone down, nodes have gone down. And by 6 months, her blood count's normal, and she's, to all intents and purposes, in a clinical remission. This is her blood count. So after 6 months, her blood count's normal, and actually, we've got no idea if she's got any CLL present from 2014 until now, because she's taken the therapy and she's well. And actually, if you look at where we are now, we last saw her just under 3 months ago, she's got a relatively normal blood count, slightly thrombocytopenic, but her circulating count's 0.018, and it's dropping down. So she's continuing to respond, and the rest of the disease is stable. The last marrow was actually almost 2 years ago, but low levels. So we can use it MRD to look at the continuing response in patients. And we've done this in our trials. So this is Icicle, and each line is an individual patient. You can see on the right the median box and whiskers of all the patients. So by 12 months, most patients are below a detectable level with a normal blood count. You can see the individual patients on the left. If you pull them out separately, some patients have got a slow progressive fall in their counts. Other patients plateau out below a level we could detect, so they're presumably developing some form of persistence, if not resistance. This patient had the lymphocyte count levels out about 3, but the CLL count's also leveled out, whereas apparently a similar patient has a continuing fall in their count. So if we use blood counts, we won't be able to know what's happening with these individual patients. And in fact, some patients are becoming MRD negative, a low level with ibrutinib. So we're going to be treating patients who have no detectable disease. I'll show you a second patient who highlights this problem. This is a farmer, 52-year-old, born in 1952, treated with FCMR, had a poor response, relapsed with 17p, was referred to us for trials, was put in a trial of venetoclax in March 14. He had massive effusions and massive nodes. Within 6 months, the scan was completely clear, the fluid had dried up. What was really impressive with this patient was this is his disease before he started treatment in the marrow, and at 6 months, he had no detectable disease by our flow cytometry. So this is the patient now. So he's got his gun back, he's back farming, his blood count's normal, he was MRD negative, but he's been MRD negative now for 3 years, and he's still taking venetoclax because he's in a trial and has had no side effects. So in the real world, do we actually need to continue this therapy? And I think that's one of the challenges which we really need to address, and we are doing in the clinical trials. So in terms of the last minute, I'll show you what we're doing in the trials now. So if we take our normal distribution of patients and we improve the depth of remission and reduce it by a log, we would predict that we would increase the cure rate to 1/3 of patients. If we do about another log, to 50%, and so on. So we can model the likely response and durability of response by the number of patients who are MRD positive, and the more sensitive tests will help us do this better. And so we're doing this within our frontline trials. This is our frontline trial FLAIR, where we're comparing initially ibrutinib rituximab plus versus FCR. We're measuring MRD and stopping when patients become MRD negative after 6 months, which actually isn't logical, so we've changed this. It's recruiting well. We've now actually added another arm. So this is our relapse trial, which shown if you combine ibrutinib and venetoclax, you'll see really deep remissions, and we'll present this at ASH, that a significant proportion are MRD negative after only 6 months in the relapse refractory patients. And so now we've added 2 arms to FLAIR, ibrutinib monotherapy and ibrutinib venetoclax, which will have now over 1,500 patients in the total trial, phase 3 trial. So this is what we're doing now. Rather than stopping at 6 months, the problem if you stop at 6 months is if you respond very quickly, you'll go down by another 2 logs, slowly by another log, more slowly by less. So what we've changed it to is to model it on speed of response. So if you drop down by a year, you'll have another year of treatment and should get below our theoretical line. If it's 18 months, you'll have another 18 months of treatment. 2 years, another 2 years of treatment. So we're defining the duration of therapy by the sensitivity of the patient to the treatment they're receiving. And so that this has already been changed in FLAIR, and we're taking this approach for all of the ibrutinib-containing arms in the trial. So in conclusion, deeper remissions in CLL result in more durable remissions regardless of the therapy we use, and you would theoretically think that would lead to less resistance because the resistance comes from the residual disease, presumably. If we're going to move towards cure, then MRD eradication is going to be critical to us doing that, and I think we have the tools now to realistically move towards cure without chemotherapy. The dynamics of response and early relapse are going to be important for individual patients, and we're using this both in my clinical practice, but we're not changing treatment at the moment, except in the clinical trials. And actually our application of MRD modelling of MRD is important to really understand the way MRD is useful to move more rapidly with our clinical trials towards a more effective strategy to stop these treatments rather than have them going on indefinitely. And finally, to just thank the group in the UK that I have the pleasure of chairing, that run all these trials, and particularly Andy Rostron, who's been a collaborator of mine for over 20 years, mainly working on MRD. Thanks for your attention.